All right, then now I screen share.
Cool. Yes.
Brilliant. All yours. It is recording.
All right.
Sorry about
Right,
the technical
guys.
glitch. Yeah.
No, that's okay. So hi everyone, I'm Nikki and I work at Auckland City Hospital and based in the Auckland dialysis unit. Today our talk is going to be about the impact of dialysis on drug therapy, and our learning outcomes for today are to understand, if we could just get a screen change. Yeah, to understand how renal replacement therapy affects drug removal from the body, and to also know about what types of factors can influence the likelihood of a drug to actually be removed by dialysis. So that's a mixture of your drug factors, your dialysis factors, and patient factors as well. We aim to understand how to maintain drug efficacy when there is significant drug removal by dialysis, and also to consider the role of a dialysis practitioner in promoting patient adherence to medications, because often you'll be the people that the patient is most in touch with in their dialysis journey. So it's all opportunities to remind them about the role of medications in their therapy. Cool. So the session outline, I'm going to go through some pharmacokinetic changes which we expect in renal failure. And so that's your absorption, volume of distribution, metabolism, and excretion, which are all factors which affect the drug concentrations in the patient's body. Then we're going to look at how dialysis can remove drug and the role of it. Sometimes it's wanted, sometimes unwanted. Drug properties that affect drug removal, properties of dialysis treatments that can change drug removal, and how can we then manage or compensate for drug loss in dialysis so that patients are still getting effective treatments. All right. So when you pick up the medication chart of one of our dialysis patients, you'll know that there are a lot of medicines to consider. When the kidneys aren't functioning well, there is that a whole raft of electrolyte and metabolic problems which occur, such as sodium imbalance, potassium accumulation, causing hyperkalemia, issues with metabolic acidosis, because the kidneys can no longer excrete acids, and for each of those, you've got different types of medications. So diuretics, people put on dietary restrictions of sodium, dietary restriction of potassium. They're told to avoid non-steroidals, which can make hyperkalemia worse, as well as in general, non-steroidals aren't an ideal treatment for the risk of increased bleeding risk. And also if someone's got residual renal function, it can also cut that right back as well. We give sodium bicarbonate as capsules before dialysis, but as you know, once people start dialysis, the dialysate is usually got bicarbonate compounds so that you can actually get away with not having to orally supplement anymore. Another function of the kidney function reduction is your calcium phosphate balance. And that metabolic renal bone disease that we hear about. So the increased phosphate, increased parathyroid hormone, reduction in calcium and calcitriol can all lead to these dysregulation. And in treatment for that, we often will have them on phosphate binders like your calcium carbonate, your aluminium hydroxide, and calcitriol. Or if some people are lucky enough, and it'll be coming soon, is your cinacalcet. And that will be funded by Imapct possibly in the future. And then, of course, when the kidneys aren't functioning, you get this problem where your kidney no longer produces erythropoietin. So natural to expect that most patients will be on a bit of epoetin to help ensure that they still get and maintain their hemoglobin. And your patients will often be dosed with a ESA or erythropoiesis stimulating agents such as Imapct, or now Binacrit is the new brand. iron replacement is a standard therapy that is often given during dialysis sessions as well. So the point of that slide was just to illustrate that there are a lot of medications that people are on, and broadly speaking, we should just know whether we need to think about them in terms of the patients going for dialysis, when's the best time to take them. In many cases, we just want to make sure that the patient at least takes them, but if there is an optimal time, it may depend on whether or not a drug is actually dialyzed out or not. So to start off with some pharmacokinetics. So can anyone tell me what is pharmacokinetics when we talk about pharmacology? Does anyone have an easy way of remembering what is the difference between pharmacokinetics and pharmacodynamics? Anyone? So, I mean, pharmacokinetics is essentially your drug handling. It's the way that the body handles a drug. So it's mapping out, what's the absorption, metabolic, and excretion pathways for a given medicine. The goal that we are trying to achieve with drug therapy and renal failure is to achieve similar free drug concentration as in a normal renal patient. A normal renal function patient, to give similar therapeutic effects. And so that sometimes requires us to reduce individual doses, or also to stretch out or reduce the frequency of doses so that you're maintaining similar concentrations in the blood. When you have a drug, the drug is absorbed via the route of administration. So orally, you will get a degree of bioavailability or amount that actually reaches the blood. IV is usually 100% bioavailable because you're putting it straight into the bloodstream. And then you've got rectal and also sometimes lung absorption if you're nebulizing drugs. So once that drug's in the blood, it then distributes to the tissues and also into other fluid compartments. Then the drug is metabolized, and that may be by the liver, kidney, or gastrointestinal tract. And to some degree, that is making these compounds into a more water-soluble form, or a form that can be excreted either in the feces or via the kidneys, if it's a water-soluble compound. Cool. All right. So next slide. We are talking about, okay, so then we know that the usual path of a drug, what happens when you've got a person that no longer has kidneys that are functioning properly. So these are what we call in pharmacology, so your ADME, so your absorption, distribution, metabolism, elimination processes. And all of these can be affected by kidney failure. Absorption of drugs, so generally that it may be from the gastrointestinal tract, so that absorption may be reduced in kidney failure because the patient may directly have issues with nausea and vomiting, and that may be caused by uremia. There's also the issue of multiple drugs like calcium and aluminium phosphate binders, which can bind up drugs as well as phosphate and stop them being absorbed as well. There's also poor gut motility in diabetic patients as a possibility. So their stomach emptying may be delayed. And then, of course, I need to mention that nephrotic syndrome. So that's a situation where you may get waterlogged tissue in the gut, which can reduce the absorption of medicines so that they are not absorbed very well. All right, the next step that can change is protein binding. So protein binding is basically caused by changes are caused by low albumin states, which can happen when you've got either because of poor nutrition, or that maybe the patient is actually losing protein because they've got nephrotic syndrome. The net effect is really that you've got lower albumin, and albumin is the main drug carrying protein in the body, and it affects distribution. And when you have drug bound to protein, it's really only the free portion, so the unbound portion that's actually free to interact with the receptors and have therapeutic effects and side effects. So the effect that sometimes happens with medicines is that not only you have low albumin, but you also have uremic toxins, which are interfering with the binding of the drug to the protein. It's called uremic displacement, and the net effect is possibly higher fraction of active drug in the plasma. This is active drug which is free to have effects, but also remember that it does mean also that there's increased fraction of drug which can be metabolized, and the liver may metabolize the active drug as well to bring about an equilibrium. So it's only with certain medicines like phenytoin where you get saturation of metabolism. So you get to a concentration in the blood where the body can't actually continue to metabolize it anymore. And then you actually reach a state where the concentrations escalate really high and the patient gets a bit toxic. Cool, so that's protein binding. The second is volume of distribution. And really that tells a story of how widely a drug is distributed in the body. So a small volume of distribution suggests that the drug is mainly found circulating in the blood, whereas a large volume of distribution tells us that the drug is probably going into tissue and other fluid compartments. Now, where this is relevant to you is drugs with a small volume of distribution are more likely to be cleared by intermittent dialysis in your 4-hour session, compared to those that reside in tissues, which are going to take longer periods of dialysis to actually get rid of it. Yeah, that kind of is one of the factors, the volume of distribution of a drug, which affects how amenable a drug is to being removed by dialysis or not. When you have renal failure, obviously that can cause edema and fluid buildup, or it can cause reduced tissue binding, and that can affect the distribution of your water-soluble drugs and so forth. Any questions so far? Hopefully this isn't too new to you and it might be things that you already learned in your pharmacology courses. But yeah, do stop me if it's not making sense. Now, the kidney is actually the site of metabolism for some drugs. So including cholecalciferol and active calcitriol, and it's also our main site for insulin metabolism. So as renal function deteriorates, we find that patients may not need as much insulin as they once needed. So sometimes you'll find dialysis patients not requiring actually that much supplemental insulin, and it might be because they're type 2 diabetic, the body still produces a bit of insulin and that's able to maintain their glycemic control. It also means that we have to be a bit careful about hypoglycemia, and a reason why we monitor the blood sugar levels too. Okay. Elimination-wise, so this is the most obvious change that happens in kidney failure as the kidney disease progresses. These drugs that are usually cleared by the kidneys, such as gabapentin and atenolol, they have reduced clearance. And it is also helpful to note that even if a drug is liver metabolized, sometimes that drug may still experience a reduction in metabolism, because in a chronic condition or chronic inflammatory condition like CKD or renal failure, you end up getting the enzymes in the system being not as efficient or may not work as well. So we know that in end-stage renal disease, drugs may accumulate because they can't clear them via glomerular filtration and also decreased renal tubular secretion, which are the two mechanisms by which kidneys are clearing medicines and drugs and other compounds from the body. And as a result, the dose of renally excreted medications will need an adjustment, and we might reduce the size of the dose, or we might increase the dosage interval so that we're achieving similar drug concentrations as in patients with normal renal function. We have ways of estimating the clearance, and that's by the Cockcroft-Gault or the MDRD, or actually more likely these days is the CKD-EPI equation, which is mentioned in the KDIGO guidelines, is a way of grading your renal impairment. Cool. So renal replacement therapy obviously is indicated when your renal function is so poor that the kidneys are barely clearing anything. And the renal replacement therapy, it only replaces the glomerular filtration type function of the kidneys, and thus it can remove toxins and drugs, excess fluid, and it can correct biochemical disturbances. All right. Now, other functions of the kidney that can't be replaced by our dialysis includes the synthesis of hormones such as erythropoietin, and that means that's why we have to supplement them, and making active vitamin D. So that's why we give your calcitriol. And given that intermittent hemodialysis is only 3 times a week, there is little or no clearance in between these sessions. So we have to dose to creatinine clearance usually of less than 10 ml per minute, unless the patient's got significant residual renal function, i.e. they still pass a lot of urine. So there's different types of dialysis, as you will know more than probably better than I. So you've got your hemodialysis and hemodiafiltration. A lot of our machines these days are your HDF, which has a bit slightly greater clearance than your conventional hemodialysis. We've got peritoneal dialysis, which is quite a passive form, which uses your peritoneal membrane as the filter. Then you've got the filtration membrane, that is. And then you've got in your intensive care units, your continuous forms of hemodialysis, such as continuous arteriovenous or CVVHD. And these provide clearance all around the clock. So not just for 4 or 5 hours, but like 24 hours. All right. So drugs may be removed by diffusion and then or convection. So this slide will show you diffusion. So in hemodialysis, you've got blood that's presented to one side of the membrane and a dialysate solution presented to the other side. And this encourages toxins to leave the patient's body, blood, and enter the dialysis solution by a process of diffusion, moving from high to low concentration. Usually the removal of drug or toxin or waste is down the concentration gradient, and diffusion is greater with the lower molecular weight drugs. So we call molecular weight is measured in daltons. So less than 1,000 daltons in general will lead to drugs being able to be removed by diffusion process. We can enhance diffusion by maximizing the concentration gradient between the blood and dialysate. And that can be achieved by this opposite direction of blood and dialysate flow. So you're always maintaining that high concentration gradient. In continuous peritoneal dialysis, the membrane is the patient's peritoneum. And so obviously there's, it's not as, it may not be as efficient at removing drugs because you've got that passive sort of flow rather than the blood flow that happens through hemodialysis filters. Cool. So drugs may be removed by convection as well. So convection, as you know, just to differentiate, so ultrafiltration is the movement of fluid under pressure, and that could be either hydrostatic or osmotic across a semi-permeable membrane, and that has ultrafiltration as a role in removing fluid. And solutes that can pass easily through the membrane pores, so they're small enough, are swept along with the water, and that's a process called solvent drag. And the removal of solute by solvent drag and convection, also known as convection, is important for middle-sized and large molecular weight drugs, or molecules which are greater than your 1,000 Daltons. So it's like the wind sweeping along leaves and dust as it blows through. Cool. Now, hemofiltration is a technique where a large amount of ultrafiltration, so more than is required to remove excessive fluid, is coupled with infusion of a replacement fluid in order to remove solutes. And hemodialysis and hemofiltration show comparable removal of small solutes, such as your urea, with a molecular weight of only 60, but hemofiltration has much higher removal of larger, poorly diffusible solutes, such as your inulin, with a molecular weight of 5,200. So we can combine hemodialysis and hemofiltration in a procedure called hemodiafiltration, and that will be what many of the newer machines are able to do. And we also can measure the proportion of drug that will pass through a hemofiltration membrane via a sieving coefficient, they call it. So a drug which passes freely through a membrane will have a sieving coefficient of 1, and a drug which does not pass through the membrane at all will have a sieving coefficient of 0. The sieving coefficient is dependent on the type of hemofiltration and membrane used. All right, next slide. So essentially dialysability of drugs. So a drug is considered to be dialysable if its serum concentration levels can be depleted through the interaction with a dialysis process. Some drugs, you'll note, are converted to an active or toxic metabolite, and they may also have, so those metabolites, when we say active, that means that they either have therapeutic or adverse effects. Sometimes drugs are converted to inactive compounds, which actually doesn't matter too much if they accumulate because they're not going to have any effect. Often there's limited information known about metabolites of parent drugs. Yeah, it's just being aware that, that there could be active metabolites which may cause effects if it accumulates. All right. So when is it useful to know about dialysability of drugs? So in clinical setting, we might think about it if we want to avoid accumulation of a drug by removing the parent drug or active metabolite. If we want to know if supplemental dosing is needed after dialysis. If dialysis is an option for drug overdose. And if a patient's clinical condition is not improving, is it because dialysis is leading to subtherapeutic drug levels? So considerations for dosing patients on renal replacement therapy. There's 3 main factors I alluded to. So drug factors, dialysis factors, and patient factors. So we're going to go through each one of these. All right, so the first factor is molecular weight. So smaller drugs are more likely to pass through membranes, and larger drugs are not likely to be dialysed, such as heparin or amphotericin. In hemodialysis, drugs with molecular weight over 500 Daltons are not likely to be removed. The second factor is the percentage of drug which is bound to plasma proteins. So only the unbound drug, so not bound to albumin, will be available for removal by renal replacement therapy. So drugs with a lower protein binding, so less than 50%, are more likely to be removed because there's more free drug, compared to highly protein bound drugs which are not generally removed. And so some of those might be like your sodium valproate, an anti-epileptic drug, really important that you maintain equal levels. It's so highly protein bound, but obviously albumin and proteins aren't dialysed out. So that drug maintains, keeps in the body. It's helpful to note that some proteins may pass the peritoneal membrane when the peritoneal membrane is inflamed, such as in peritonitis. Sometimes we find that drug clearance might be, and protein bound drugs might happen if you're in peritonitis. And antibiotics with low protein binding may be given orally or IV during peritonitis episodes to kind of just ensure that you're getting sufficient drug in the right places to treat infection. Okay. The other drug factors that we're thinking about is for a particular drug, what's the volume of distribution? And it's important because only free drug in the plasma is available for removal by dialysis. I'll give you an example. When you look in the textbooks, you can find out what the volume of distribution is of a drug, and if it's small, and when we say small, it's like less than 1 litre per kilogram, it is likely found in the vascular space rather than in the tissue, and therefore more likely to be cleared by dialysis. Drugs with a large volume of distribution tend to be highly tissue bound and lipid soluble, such as your diazepam, your benzodiazepines. And this means that only a small amount of this drug is present in the blood and therefore available for clearance. For intermittent hemodialysis, only small fractions of drug with a high volume of distribution will be removed. And this is in contrast to continuous renal replacement therapy, where drugs with a high volume of distribution will be more effectively removed because of the equilibrium between the plasma and tissue levels, which are constantly changing because you're dialyzing full time. The next factor is water solubility. So more water soluble drugs are more easily dialyzed. Examples are your gentamicin and your aminoglycosides. And then lipid-soluble drugs tend to distribute into tissues more than stay in the blood. Cool. All right, so drug factors. So another drug factor is how much of total body clearance is renal clearance of this medicine. So drugs that are usually cleared by the kidneys are more likely to be cleared by dialysis as well. For example, if renal excretion is less than 25%, dialysis probably has little influence on the total body clearance, and then dose adjustments for dialysis may not be needed so much. Steric hindrance. So that is really about the atomic arrangement of the drug molecule and will affect the ability to pass through the dialysis membrane. Cool. So even if a molecule is small enough to be removed by dialysis, the atomic arrangement of the drug molecule will affect its ability to pass through the membrane. Next, another factor of the drugs, there's lots of them, is the timing of administration. So for intermittent hemodialysis, if a drug is significantly removed, then it should be given after the dialysis session. Otherwise, a proportion of the drug will be removed and its duration of action will be reduced. It's preferable to adjust the timing of regular doses on patients on hemodialysis rather than giving additional doses. So if you can get the drug to be timed so that it's every 24 hours, which coincides with the end of dialysis, that's easier than giving the dose every morning and then you have dialysis and having to give a supplemental dose afterwards. And saying that supplementary doses are also helpful when you have drugs with low volume of distribution and a narrow therapeutic range and you want to maintain efficacy. Example might be meropenem, where you often need to give a supplementary dose if you happen to have dialysis after you gave the daily dose. When you're thinking about continuous, I think it's just back a slide, please, Balaji. So for continuous dialysis and CAPD, since these are continuous processes, you don't need to schedule doses around dialysis sessions because your dialysis is sort of ongoing. So it's almost like a working kidney. Therapeutic index, you may hear this term. That's about the range or the window between the minimum effective dose and the dose that causes toxicity. So most drugs have a broad window, so rigorous adjustment of doses in patients undergoing dialysis may not be so necessary because you've got a bit of a flexible range over which the patient's drug levels can go between without causing harm. However, some drugs like your gentamicin require dosage adjustment, and blood level monitoring is really essential. All right, so those are all the drug factors that we're thinking about, and all of these considerations are taken into account when you look at drug textbooks or reference guides about the dialysis of drugs. And now, basically, that however much is removed, or if it is removed or not, will depend on those specific drug factors we talked about. Now we're going to move on to dialysis factors now. Dialysis factors are a little bit more obvious. So duration of the dialysis, so longer or more frequent sessions increases the clearance of drugs. And then flow rate, so higher dialysate flow rates or higher blood flow rate increases your concentration gradient, so that you've got more efficient diffusion as well. Composition of the dialysate, so whatever is your levels of calcium or potassium in your dialysate can affect diffusion processes, and sometimes we do adjust those to depending on if a person's hypokalemic or hypocalcemic. And then dialysis membrane permeability. So there are many different membranes around, and the type will affect drug removal because of changes in the permeability and the composition, which might favour the removal of different drugs. Higher permeable membranes may allow the removal of larger molecules up to 30,000 Daltons. Okay, just a word about peritoneal dialysis. So for like CAPD, the membrane we use is the peritoneal membrane, and therefore the health of the membrane is really important. I mentioned before that during peritonitis, the membrane becomes more porous and you'll remove a larger proportion of drugs and solutes that way. So in peritoneal dialysis, you've got diffusion and convection of solutes which occur between the capillary blood and dialysis solution in the peritoneal cavity. And osmosis will also remove excess fluid. But the factors affecting drug removal by this process include, again, the molecular weight of the drug, the health of the peritoneum membrane, volume and exchange rate of dialysate in the peritoneum. So some of your automated peritoneal dialysis can change that, composition of your dialysate, and osmotic concentration gradient between the plasma and dialysate. So with higher glucose concentrations causes a bit of a higher removal of fluid and sometimes the solutes which get dragged with it. All right, the next slide is about continuous renal replacement therapy. So this is where convective, transport and ultrafiltration are the main factors for drug removal and hemofiltration, as we've just talked about. Most important factors influencing drug removal are the drug factors we've previously discussed, and also drug size, so less than 2,000 Daltons are readily cross the membrane and are removed. And some other specific continuous renal replacement therapy factors include how permeable the membrane is. Mostly all of these membranes are all high flux. The system pressure, so whether that's arteriovenous versus veno-venous system, where are you using a pump to generate the flow rate, or are you using the patient's actual cardiac function to do so. Convective therapies may clear large solutes better than diffusive therapies. All right. So the dosing schedule in different renal replacement therapy include intermittent hemodialysis. So between so intermittent hemodialysis probably achieves about 150 to 120 ml per minute clearance during the dialysis session. And remember that in between dialysis there's probably little clearance, so that's why we dose according to less than 10 ml per minute. Dosing schedule for intermittent hemodialysis. So drug is likely to be removed, so give after procedure for most drugs. That's just, I guess, one of the things to be, to be safe, give it after. But if it's too inconvenient, then we just want to make sure the patient gets the drug in the first place, but to realise that some removal may happen. Intermittent hemodiafiltration, remember, it's more efficient than drug removal than hemodialysis. And we want to dose after dialysis as well. For CAPD, theoretical GFR is about 5 to 10 ml per minute. So there's no specific schedule. It's just like dosing as in a person that wasn't on dialysis. And then you've got your continuous therapies. So these various clearances allow that are achievable in the dosing schedule. So limited dosing guidance really for these. We do refer to some papers about the clearance of select medicines, and similar dosing schedules occur between the modalities, but the pumped systems may have greater clearance. So your veno-venous often have a pump, so they can achieve higher levels of clearance. Cool. So patient factors. So we've talked about drug factors, dialysis factors, now patients. So we talked about pharmacokinetic changes in renal failure. So just going over that again, so protein binding may be reduced, so more drug is available for removal, more net active drug is available floating in the circulation. Volume of distribution can change for some drugs. For water-soluble drugs, the volume of distribution increases in edema or ascites, where you've got more fluid in various compartments, and it decreases in volume depletion or muscle wasting. Another patient factor is the medical condition being treated. So predicting clearance is important to avoid overdosing patients, such as in a severe infection where you're wanting to make sure you've got therapeutic antibiotic levels. Residual renal function, so urine output greater than 20 ml per hour, for example, may contribute to drug excretion as well. So we have to take this into account if you've got a person that has still got some remaining renal function in addition to the dialysis clearance. Okay. So knowing all this, we need to try and maintain drug efficacy by a number of ways. Next slide. So to maintain drug efficacy, if significant drug is removed by dialysis, it's best to dose post-dialysis if possible. Supplemental dosing may be required if we have to re-establish or maintain a therapeutic level as the drug concentration decreases due to dialysis. And based on the half-life of the drug, the dosage interval will need to be adjusted, and then we can do that in relation to the hemodialysis schedule. And the key is to really replace the amount of drug that is removed during the dialysis session. So sometimes it might be 20%, maybe 50% of the usual daily dose. Now altering drug dose, so sometimes dose varies according to the type of dialysis and can change the amount or interval between doses as well, or both. So yeah, it's actually interesting that with some of the continuous replacements therapies, you actually have to increase the dose because you might get higher clearance than in a person that has normal renal function. Check drug concentrations. So it's really essential that we do monitor drug levels if there is that facility. Now, not every drug can be therapeutic drug monitored. It's only drugs which have a known relationship between plasma concentration and effect. So sometimes we'll check your trough concentrations of their gentamicins and vancomycin, for example, to try and guide our treatment and let us know that we're on the right dose. So where can we find this information? We can look in product data sheets, so they're available from MedSafe. renal drug database, which actually is a subscription required that our Medicines Information Service at Auckland Hospital has access to. There's the Dialysis of Drugs Handbook, which you probably have readily available in your dialysis units. And then you've also got, if you've got a pharmacy, a pharmacist in your hospital or a local medicines information department that can look into the use of drugs in dialysis in a bit more depth. Can I ask, just before we move on, has anybody ever used the MedSafe data sheets or Australian data sheets in their practice? And what are you looking up in those on a daily basis?
Sometimes we do have like own unit protocol policy, like if say CMDHB, their own CMDH-based protocols, policies in the PANOV. We used to follow that protocols and we used to follow the drugs database. Like for example, like what you told, gentamicin or vancomycin.
Yes.
Like for gentamicin, doctor will be already prescribed, okay, this much of where if less than 3, you need to give 80 milligrams of gentamicin. But for vancomycin, they'll be having like 5 readings, like depends upon the vancomycin level, how much it will be all, it's uploaded already in the PANOVs.
That's really helpful. So yes, local policies and guidelines that you've got.
So we need to download the guidelines and we used to stick it in the like usual nurse station regions. So access,
no, that's good. So with the policies and guidelines, it's really helpful if you've got like nomograms that your staff are having to follow. And so that will give you a lot of information. I forgot to mention here and list here the New Zealand formulary. So you guys should have access to the New Zealand formulary. It's a freely access across New Zealand. And it also links to product data sheets. In the data sheets, they often have a section that is for dosing, and sometimes you'll be lucky to find a section about what to do in a patient with end-stage renal failure who needs dialysis. But there's an overdose section of MedSafe data sheets, which sometimes can explain whether or not dialysis is useful at treating overdose. So, for example, for dabigatran, even if a patient is not actually in renal failure, sometimes dialysis is used to treat overdose of that drug. Cool. Are there any other references that people are using in their practice? So I think, these are probably some of the main ones that help guide prescribing, but also I do get, questions frequently from staff asking, should I be giving this drug before or after dialysis? Patients just come from the ward. Am I best to just wait until the patient returns to the ward? And like how important is it to get the dose on time versus should we just wait till after? Can it wait till after the dialysis session to maximize the efficacy and the drug levels? Cool. So if you guys got any questions about the resources, do let me know. So we've got a case study now, just to talk through. So we've got a patient, Mr. BG. He's a 55-year-old man on intermittent hemodialysis 3 times a week. Now, he develops a productive cough with fever and chills, and he's admitted to hospital. And he's found to have lower respiratory tract infection, and he started on Augmentin or amoxicillin clavulanic acid at 1.2 grams twice a day in hospital. So he gets a dose of the Augmentin at 8 a.m. and he'll be coming to you for dialysis at 6 o'clock p.m. The staff nurse at the ward is not sure whether to give Augmentin before he goes to dialysis or not. And what things should we consider in this situation? So I guess let's pretend that the time is 4 o'clock in the afternoon. So the staff nurse is wondering whether or not to give the Augmentin before she goes off shift, or if she should give it afterwards. So let's just have a talk about like what types of things are you guys thinking, or you've got questions about the drug that you might want to find out.
We might think about what the half-life of Augmentin is.
Okay, yeah, that's good. So yeah, is what's the half-life? So is it 8 hours? Is it 12 hours? And this is the half-life will differ depending on the renal function. Yes.
And we need to consider whether it's a water soluble, it's a fat soluble.
Yes. Yeah.
Yeah.
Mostly water soluble. Yes.
And
we should also consider what time the next dose is. If, for example, if you're planning to give it after dialysis and the next dose that the patient is getting has very short time duration between 2 meds, that might not be.
Yeah, that's really, that's a good thought, Ruchi. Yeah, so when are we going to be dosing after the dose that we give? Because is it going to be convenient timing? Does it matter so much? So back to your thoughts about half-life, like how important is it that it's exactly 12 hours apart? Or is it okay if it's like between 10 and 14 hours apart, like, just depending on what's convenient? Yes, that's very good. Anything else?
It would be nice to know if Augmentin is dialysable. What if it is removed? Yeah.
Yes, so essentially, yeah, we're trying to make a decision about, is it significantly removed? And so yeah, most drugs will be removed to some extent. Yeah, so that's good. We've covered off your drug factors. The other things are dialysis factors. So thinking about, next slide please, Balaji, is dialysis factors might be, is the patient on hemodialysis or hemodiafiltration? Is the drug removed by this particular membrane? And then from a patient factor point of view, how sick is the patient? And what happens if the infection is not treated, or if depending on the drugs, like therapeutic window, is it such that if it's got a really narrow window, then the dosing might make a difference, dose timing might make a really big difference. Okay. So where to look for information? So we'll have a look at the manufacturer's product information. So know that you can find this information from medsafe.gov.nz, but also there's links from the New Zealand formulary that allow you to look up this information. So the data sheet for Augmentin IV shows you that the dosage and renal impairment, it depends on your level of renal function. And so if we're going to go straight to your severe impairment patient, less than 10 ml per minute, you can see the dose recommended is 1.2 grams IV stat, followed by 600 milligrams IV 24 hourly. Now, dialysis, it says, decreases the concentration of Augmentin, and it recommends that an additional 600 milligram dose may need to be supplemented at the end of dialysis if it was quite, if you were ending up having dialysis quite too close to when you just gave the last dose. So you'll see that this really illustrates that manufacturers are quite conservative with their dosing. They may not, they may want to cover themselves, and so they probably won't openly say, actually, yeah, it's okay if you use quite high, higher doses in case of toxicity or adverse drug reactions. All right, next. So then you've got, there's also other references. So we try and look for information in more than one resource, just to make sure we've got adequate evidence to base our decision on. So this is an example of the information in the Renal Drug Handbook. And this is from the UK. And it's saying here, split it into 2 different drugs. This is your molecular weight. So it's, it's quite, it's not too large a molecule, it's less than 1,000 Daltons. It's got a percentage of protein binding, which is relatively low. It's maybe 40 to 60% excreted unchanged in the urine, which means that renal function does play a clear role in removing drug. And so you want to make sure you're not going to accumulate drug if you haven't got good kidney function. The volume of distribution you can see is relatively low. It's less than 1 litre per kilogram, which leads to a low amount in tissues and other compartments. So it's mainly in the vascular space, which might count towards being cleared easily by dialysis. And then you've got the half-life, which is, it looks like it might increase it does increase between a normal and an end-stage renal failure patient. So it's going to last in circulation longer, which suggests that the dosing that you choose will probably be like less frequent. So you could get away with less frequent dosing and like draw out that dosing interval. So the dose in renal impairment, your dose in normal renal function, your is in 30 to 50 ml per minute, but you can see at level less than 10 ml per minute that they're recommending 1.2 grams stat, followed by 600 milligrams every 8 hours, or 1.2 grams every 12 hours. So there's a little bit of a range, but that's in general what you'll be seeing in practice. Oral dosing, we don't usually need to adjust that too much for renal failure. So, and you can see there that the dialysis information, so it tells us that it is dialyzed by CAPD, hemodialysis, and high flux or HDF. Cool. So you can see that the UK renal drug handbook is a little bit more, allows a higher dose than what the manufacturer is actually saying. Cool. And then let's have a look at another reference. So the next reference is an example from the Dialysis of Drugs handbook. So check the most recent edition, but you can see there that by conventional and high permeability clearance, there is some differing advice. So conventional dialysis, it says that dialysis is likely to enhance the plasma clearance by 30% or more. And supplemental doses may be required, or dosing after dialysis should be considered. Now it says that for high permeability hemodialysis, there's actually no published data, and this is the case for a lot of medicines, but information could be extrapolated from studies using your conventional dialysis techniques. And there might be significant drug removal is likely during high permeability dialysis. So peritoneal dialysis wise, it says it's amoxicillin's not removed, but clavulanic acid is. And you do need, well, both components for augmentin to work as it's supposed to. Cool. So yeah, I think the L really means likely removal. Following this research, you conclude that amoxicillin and clavulanic acid is significantly removed by hemodialysis, and augmentin 1.2 grams given at 8 o'clock. And then the patient is coming to you for dialysis at 6 o'clock. So it would probably be best to give the second dose after the hemodialysis session. So just be able to get away with, like, the lowest effective dose, so that you're not having to think about the need for supplemental dosing after the session. Yeah. Any questions about that, that little case study and how you might apply that to drugs that you see in practice?
No, that we are clear.
Cool. Okay.
Yeah.
All right. So roles of a dialysis practitioner in medication management. So as clinicians, I mentioned you will be talking and seeing these patients, and their main point of contact with the healthcare system for these people. And so these are all sort of tasks which, as a pharmacist, we are really we focused on getting accurate medication history. And part of the, the knowledge gap is sometimes we don't know what exactly the patient's doing with their tablets. They could be dispensed from the pharmacy, but a patient may not be taking them, and you probably have a good idea of the likelihood or how reliable your patients are at doing so. when you ask about a patient's medication history, we like to know not just about the drugs, but also what other things are they taking, like herbal remedies, complementary medicines, drugs over the counter. Also thinking about what pharmacokinetic changes occur in renal failure that we talked about, which might change like the absorption or distribution of medications, and might affect if the drug is, so knowing if a drug is normally excreted in the kidneys, might there need to be a dose review? Is the patient on the right dose for their level of function? And thinking about, is the drug dialysable? Do I have to worry about reminding the patient to take medicines afterwards or not? Thinking about what pharmacodynamic changes occur in renal failure. So what is the onset and duration of the pharmacological effect? Is the drug nephrotoxic? And if so, at what levels? And what are the potential side effects of a drug that we're giving someone? And this could also affect, like, the way a patient presents. Are they showing signs that they're actually got too much drug on board? An example of a drug which you might encounter quite often is gabapentin. And we often see patients prescribed high doses of gabapentin, either in error or unintentionally. And you may see signs of like dizziness, confusion, unsteadiness on feet, which may be a sign that they could have accumulation of a drug on board. All right. So you have a role in understanding, medications. Will alterations in the normal drugs dosing schedule be necessary on dialysis days? So it's actually really reassuring to know that, some patients are quite independent with taking their medicines, and they understand this concept quite well. They know that on dialysis days, they take different doses of the antihypertensives or certain medicines, depending on their dialysis schedule. Is supplemental dosing necessary after dialysis? Do we have to think about that? And that might be if you've had to change a patient's dialysis session to be earlier in the day, and they're actually on a drug which has been dosed sort of at equal intervals at a certain time each day. So just kind of bearing that in mind, and thinking about how is the drug likely to interact with other medications. So there's a raft of different factors which hopefully the prescribers will have taken into account. But drug interactions is a big topic in itself, but there is information available from New Zealand Formulary, would be probably my recommendation to get familiar with, as that's your going to be your key source of drug information if you're ever wondering about the drug, the way that's been prescribed, or administration information. We also have a role in the dialysis unit of ensuring that there's correct timing of serum levels taken in regard to medications and electrolytes. So an example would be, say, and I think there'll be different guidelines in each dialysis unit about when they should be dosing gentamicin in relation to dialysis. I know that at Auckland we are still doing dosing of gentamicin after dialysis sessions, and we'll be basing the dosing on the serum levels that were taken as the patient's coming onto the machine. Cool. It might be helpful just to note actually on the before we move on, largely the vancomycin levels. So vancomycin, now in some hospitals we're moving towards a different way of monitoring vancomycin. So instead of relying on trough levels, we actually will take random levels now. It's just important to know what time that was taken, because now we plot the random levels on a graph, which can is basically a graph of normal distribution of levels that you'd expect for a given patient in our population. And so we can it's called next dose, and that allows us to kind of predict whether a patient's on the right dose, depending on their exposure or their predicted exposure, based on we usually have like maybe at least 2 levels taken within a 24-hour period, and you can kind of map it out and see if it, yeah. So it is kind of, there are different protocols in different hospitals, just to make sure that you understand what type of timing a patient's on.
And that too, when you have a unit which is a standalone unit out in the community, and you don't have access to send the drug level to the lab to, in time to get reported, so that you can whether to give it or not, it makes it a little challenging as well, especially.
That is really challenging.
Because we are at the Albany site, where people on vancomycin is difficult, because by the time we get we need to book the sub 60 to send the sample to the lab, and lab to process it. By the time we get the result, it might be too late, or so.
And are you taking the level, Balaji, before so as the patient's going onto the dialysis machine, and then trying to decide whether or not to give a dose after the session?
Yeah, I think we used to be that kind of a protocol. We still do that.
Yeah.
But we also, there is a different dosing where there is a guideline in our protocol. I think it's a regional right now. I'm sure, and you can work out whether based on the levels, and whether to up it or decrease it, the amount of vancomycin that we give.
Yeah, I think we've got a similar nomogram to you, perhaps.
Okay.
Yeah, but it does rely on timely access to the results, so that you know when to start the infusion before the patient has to go home.
That's right. I know now they have a unit in Kereru as well. I'm not sure they have access to the lab, or the blood has to come to ADHP for process.
I'm not sure. But yeah, definitely a challenge to make sure that the information's available, so you know what to do.
Okay.
Thank you. Okay, so the other areas where we can make a difference, providing education which is tailored to the patient needs. So you often see that a patient's health literacy might become clear through your interactions with the patient. Knowing where to find information, and I'll point you to the New Zealand formulary will tell you drug information about a particular medicine, like prescription, as usual prescription, indication, expected effects, how often we should be dosing it, recommended routes, any major adverse effects. So sometimes patients will ask questions about their medicines, and they may, because you're the first point of call, they might ask you to help them with some of that. I should also note that the New Zealand formulary has links to certain medicine patient information sheets, which are freely available. So if you ever go to a certain drug, you can look down and you'll see that there's patient information, which is curated, really well written, simple drug information, which is written for sort of lay person, which is maybe a useful resource if you are in a situation where you don't have any other one to ask, or it's a pretty simple question that you just need to help the patient understand a bit more, but also noticing when you need to refer. So when might you need to ring the pharmacist to come and explain something a bit clearer, or ask the prescriber as well if a patient's got really major concerns about taking medicine. You also have a role, I guess, in helping foster adherence. So adherence being voluntary cooperation of the patient in taking medications as prescribed. So taking the right timing, the dosage, and the frequency. So you're in a position to have those types of discussions sometimes, and letting the rest of the renal team know as well. If you're finding that the patient is probably unlikely to be taking all those medicines that we're sending to them in blister packs, for example, or if you've noticed that they don't know how to use the pack properly, or they're returning almost unopened packets to you. So next slide, just a little quick whiz around about why does adherence matter. So we know that even the most effective therapy is not useful if the patient is not getting it into their system. And some of the predictors of medication adherence, just next slide. So there's a lot of them, but you can see that a lack of insight into health, lack of beliefs about the benefits, any concerns, all these sort of play into whether or not a patient is going to take a medicine or not. There's also cognitive impairment, complex treatments that we're trying to prescribe for people, just like the wrong social situation can also play into whether or not someone continues to take it. And yeah, we all notice like missed appointments, missed dialysis, previous behavior, which might play into it. Did you know that 25% of patients do not initiate a new prescription? And each day, 15% of patients do not do what they're prescribed. And overall, 40% of patients will have discontinued therapy sort of at 12 months for various reasons. Next slide is just a long list of things which can affect a patient's adherence. Patient satisfaction, drug and alcohol abuse, discrimination, quality of life, depression. So yeah, there's a lot of things, including like transportation, can't go get the drugs. There's a few things that have come up like pill drop and other pharmacy services that are able to kind of help with those types of things. And you'll know that a lot of people are using blister packs now to help them adhere. So in promoting adherence, we can help patients to understand why treatments are being given. And keeping it simple, you know, that this is for the treatment of your infection, and it's likely to be a longer term because the infection is in the bone, for instance. Or yeah, giving people sort of a purpose for why they have to continue taking this drug. Encouraging active participation in care, getting them to like listening to their concerns about why it's hard to adhere. Trying to simplify regimes so that they're not taking medicines 5 times a day. Providing consistent continuity of care and supervision of the patient. So being able to assist with like your vinaigrette administration in the unit. Providing them with feedback about how they're going, positive reinforcement. Hey, you know, your blood tests are looking really good this month. I think you've been working really hard with your phosphate management. Referring appropriately if they need more information or they've got tricky questions that aren't outside your scope. And encouraging family support as well, because you'll be able to see the family visitors that come with them to dialysis. Cool. So overall, that brings me to the end of my talk, but I'm happy to answer questions. So today we've covered the physicochemical drug properties which affect drug removal, including, and these include little binding or no plasma protein binding, which could help with removal by dialysis, low molecular weight, high water solubility, low volume of distribution, and the fact of a drug usually being cleared by the kidneys. All of these add up to a higher likelihood of significant drug removal. In a patient on hemodialysis, for drugs with significant clearance, dose after dialysis sessions. And hopefully just touched on the topic of medication adherence. It is a really complex activity, and so we need to tailor education to the individual patient and yeah, listen to what they're saying and addressing their concerns. All right. Now, these are some of the references that we used in writing this talk. But yeah, open to any points of discussion that you've got about your practice or frequently asked questions.
I have a couple of questions for you, Nikki. One is
Yeah.
someone who is a renal patient who has got a severe burn.
Yes.
And will you consider the dosing of medication because he lost quite a bit of water through the burn, loss of water? Do you consider differently? And another question is, if someone is severely malnourished
Yes.
The way you give some of those protein-bound drugs, which is highly less water soluble drug, you're administering to someone malnourished, will you consider different dosing compared to the well-nourished one for the same? Sorry.
Yeah, so I guess, with a malnourished patient, potentially low protein and potentially lower protein binding. I mean, I don't think that alone would be a reason to dose a drug differently. Just trying to think of an example, like, for example, warfarin. I mean, we're not dosing based on those theoretical principles because we're able to monitor and adjust dosing. Any other protein bound? I mean, your anti-epileptics, they tend to be dosed more based on the renal function rather than the fact of how much protein binding might be there. But I think it's a good thought, and that's like why like all of this is a bit of like theoretical understanding of what might happen to these medicines. And I don't think just based on those specific circumstances where we'd actually decide to like, I can't think of an example of increasing the dose just because a person's malnourished, or reducing the dose because we might have more free drug concentrations. A lot of the time with the protein binding issue, probably the only drug which we've seen significant problems with is phenytoin, and that's not used very often now, but it's about 90% protein bound. And so if you've got a patient who's got low protein in their blood, they may potentially have an increased free fraction of active phenytoin in their body. The good thing about phenytoin is that we can actually monitor the levels, but in monitoring you can actually sometimes see that because when you've got a lower protein concentration, you actually have a higher free drug, and therefore you may need lower doses in that circumstance, and the reason is for that drug is because you have a saturable liver metabolism. So your liver can only metabolize so much of the drug. So if we have a certain level in the body of phenytoin, you kind of reach a point where you can't metabolize even any more of it, and that's why we see like issues with accumulation. I think that's probably one of the few drugs that I can think of that actually were dosed differently because of their lower protein. Not just because of malnourishment, the low protein might be from other reasons too. But yeah, a lot of our elderly patients. So we now are actually moving to use a lot of anti-epileptics, which aren't so reliant on these factors. So ones like levetiracetam you may see a bit more often, sodium valproate, where they've got a bit of a not so narrow therapeutic window. So you've got a bit of flexibility there.
Okay, yeah, thank you.
Yeah, I'm not sure about the burns issue. I think because if you are losing a lot of water, yes, you may have that change in the distribution of drugs which are water soluble, but probably, and I think one of the things I should note is that with any of those pharmacokinetic changes, they're a consideration of what might happen, and then it's kind of just thinking about all of those together instead of just like an isolated one as being a cause for change. But yeah, it's really important that these things could play into it.
Thank you.
I have a question.
Yeah.
So I was doing a few therapeutic plasma exchange for a post-transplant, which was acute rejection, and that patient has got this heaps of medications, including tacrolimus, and I wasn't sure if the medications the time had to be deferred because we're doing the plasma exchange. So do you have any suggestions on that?
Yes, so plasma exchange is quite different in terms of drug removal, and so it is a different set of like principles that we consider with plasma exchange, because you're actually, this is filtering out proteins, so there will be different references to check to determine whether it's going to remove that particular drug. And I can't remember them like for off by heart, but I know that what you're talking about, patients who are like a transplant recipient, they're often on a lot of transplant immunosuppressants, and so it is important to know whether or not what should they do with those drugs. But yeah, just to note that there are different references which will, which will tell you if a drug is exchanged or not, and whether that means that they need to dose it after. So I would usually look up individual medicines to see if it's likely that they'll be removed by, by plasmapheresis. There's a few review articles which I tend to go to find that information, because it's not as readily available as dialysis of drugs.
Yeah.
We do have a schedule, some patients who are on chemo drugs and they're also needing a plasma exchange, and we will look at the timing of the drug and when we can actually start the plasma exchange procedure. So you need to have that, post chemo, you need to wait for that 12 to 24 hours before you can actually put them on plasma exchange, because you lose probably some of it will be removed. So we do have a specific protocol around the timing of the treatment and timing of the chemo drug for people.
Cool. And is that like a white matter guideline?
Yeah, people with multiple myeloma.
Really good.
Yeah.
You've actually reminded me, like we've got patients that might need cyclophosphamide as part of their treatment for if they've got like glomerulonephritis, and so yeah, we do need to wait that 12 hours after dialysis session, or after you've given the drug. So you might give your cyclo in the morning, you might want to wait at least 12 hours before doing a dialysis session or a plasma exchange. Yeah.
Questions? Any other questions? I think that's it, Nikki. Thank you. Thank you for your time, and we really appreciate it. And
you're welcome, guys.
I know you had another session in the morning, right? Like you finished at 1 o'clock.
Yes, I was teaching some undergrad pharmacy students about medicines information, because that's my other job. And yeah, so lots of talking today. So hopefully everyone's taken away something.
Definitely, I guess.
Cool.
So, all right then, I'll stop recording now.